Welcome to the Registry Insider. I'm Bill Seifarth, the CEO and Executive Director of the National Registry of EMTs. In today's episode, we're talking about the importance of the affective domain and empathy in the EMS classroom. And joining me is Meghan Williams from the Borough of the Manhattan Community College, and Kenny Navarro, who is from our content team and a program manager there at the National Registry. So thank you both, Meghan and Kenny, for joining me.
Thanks for having us.
So the reason why both of these two are joining me is Meghan is she's going to be pursuing her doctorate degree in the affective domain and further studies in educational psychology, but also Kenny is pursuing his doctorate degree, PhD, in empathy. So thank you both for joining me. Obviously, you're both entrenched in the field of EMS, but interested in the affective domain and this importance of these soft skills with EMS. So thank you both for joining me.
Yeah, of course.
So we'll start off with you. Can you tell me a little bit about your background and your passion, I guess, for the affective domain and why it's so relevant in EMS?
Absolutely. It certainly is a passion over the past 25 years or so of joining the EMS force. I was going to be a psychologist. This was not my career field. There was a sign that said volunteer, and I said, sure. They told me college would be so much harder. I'll do that too. And everything throughout my career, as I've moved up and been able to do more, is giving back to the community. And it started from, oh my gosh, this is so messed up. We should do better, right? And looking at it and going, well, why aren't we kind of more compassionate with my psychology kind of lens and saying, why aren't we doing better patient care? Why aren't we doing better as people? And so from there, I kind of was driven up to teaching and driven up to this passion for integrating all of the affective domain. We didn't really call it that back then, but bringing all of this in. And I've seen such amazing differences in students from 15 years ago to even this year as I continue to develop out those behaviors in the affective domain. And it's really a fascinating journey to see how they retain some empathy. We were talking about empathy before, how they retain the affective domain and how they retain the behaviors, and then how they are changing a culture. And the affective domain, it's all about that. It's not about the grades, and it's not about
that soft
the skills.
Yeah.
It's the soft skills, which we're all chasing in higher ed as well.
Awesome. Kenny, how about your story?
So I do some work with the American Heart Association, and I guess what first got me interested in this direction, it was probably 30 years ago or so, was the clear data on gender disparity and outcomes for lots of cardiac problems and cardiac arrest even. But what really cemented it was when I was working at a university, and the EMS system that we were involved with, we did an analysis once of our pain control protocol and how we were doing that. And of course, noticing then that, I mean, it was a huge system. It was huge, 2 million people. And we barely gave any pain medication at all, regardless of what the condition was. And so we started looking closely at who was getting pain medication and who wasn't. And then looking at the research, and it's clear that there is racial disparity in who gets pain medication. It's a dirty, I guess, little secret that we have in EMS about, some groups don't get pain medication based on their race. And so I started getting interested in that, and then trying to figure out why. Why is it that this group gets pain medicine and this group doesn't, but they have the same complaints. They have the same level of pain. They have the same everything. And that sort of got me looking into empathy on how it's, there may be an empathy component here. So that if you could improve empathy in that group, then could you take care of these patients better, give a better outcome for them? So that's how I got started.
Good. So the importance of these soft skills, empathy, and more broadly, the affective domain, is something that EMS educators often shy away from, and or because they don't know how to measure it, or they're afraid to measure it. So what can EMS educators do to better assess the affective domain and make sure that their students end up being competent clinicians who are empathetic? who have a stronger emotional intelligence, who have the ability to better interact with patients and have more positive outcomes. What needs to happen, Megan?
So through the years, I've certainly treated this, I've gone through the spectrum, right? It's so much easier to just grade. The cognitive, the skills, check off
That's
the
easy.
checklist.
That's
That is
easy.
so easy.
Yeah.
And the affective domain, I started out by just shying away from as well. And then I really started to look at it in a little bit of a different light, that it wasn't this enemy, it wasn't this evil thing that it's going to trip me up. It was my superpower. It was we get to set this culture and these behaviors and this affective domain on day one. We get to interact and change the community. And when I started thinking about it in that term, I started also looking at, how do I make this objective? Because this isn't a gotcha for the students. That's not the community I want. I want the community of, we are working together towards your goal. And I started there and I said, okay, you know what? Everyone that comes in, EMT, CFR, EMR, whoever they are that comes into the classroom, the first thing they do is, who do you want to be when you graduate? And I set that tone for, this is what we are moving you towards. And then I spelled out very concrete things, and it's still a moving target, let's say, that it's still continuing, but I said it with time management, and I said it with, when someone walks in the room and I'll find a coworker that they don't know on, 2 floors below, when they walk in the room, what are my students doing? Are they ignoring them? Or are they asking them, hi, can I help you? And really moving the affective domain towards objective things that students can kind of hold on to while they learn it, and then supporting that community and culture. I've often told my students, take the vacation. And that, I don't know, when we went through medic school, that was
controversial, yeah.
Oh no, you can't do those things. And that, all those things help to change that community and help to build those affective domain skills, and then help to make more empathetic students as they continue on. So one of the things I'm going to be focusing on is exactly that, is looking at those students that have developed this community throughout class, and where are their empathetic scores and their emotional intelligence scores throughout the class and then after. So I think it starts with these really concrete, and they can be 2 seconds. My friend in the hallway when we were walking up to work was more than happy and really thrilled to come into the class and just, let's see how they react. And I've had a host of reactions, from they ignore them completely and I come in the class after the 10-minute break and they're still in the back of the class, to the student the entire class has kind of stopped and said, this is the paramedic class, what can we help you with? Right? And building that community and building that culture in really concrete ways and objective ways, but letting the students know on day one, these are the things that we're looking for. And then they just organically grow out from there. And it's really exciting to see how those behaviors grow, and then how the affective domain grows with the different ideas. And students will come up with that too.
So Kenny, how about you? Because obviously you're quite an experienced educator, but from an empathy perspective, which is your passion, how do we instill that in the students?
It's really interesting that, when empathy, the educational component of empathy and measurement in medical people really started with the physicians. And when it first started, there was this belief that empathy could not be taught, that it was not you either had it or you didn't. So it was sort of innate.
So this concept of bedside manner was
and the physician community, there was a big sort
Especially
of backlash
surgeons.
against it, that you can't, that they either have it or they don't. But then as the research started to come in, it was clear that certainly everybody starts off with a baseline measurement of empathy, and then something happens over the time. It goes up or it comes down depending upon the circumstances. And at least with the physician community, that has also translated into the paramedic group, is that empathy, when you get this baseline and go through school, it stays pretty much at a baseline, and it's not a bad. I mean, I don't mean like you start at psychosis and then you go up from there. You just start at whatever the baseline is, and then once they start interacting with people. So like in medical school, when you get to that third year and you're actually doing clinicals and you're interacting with people, empathy scores go down. Paramedics, same thing. Once they get out of the classroom and they're starting to do their internships and hanging out with paramedics and taking care of patients, empathy scores start to go down. What I think is interesting is whether it's the patients that bring those empathy scores down, or is it those paramedics, preceptors, that have a different perspective than a new person.
So kind of transfer of feelings, like this is not a positive environment, therefore you have to have a negative perception as I do.
That's right. We don't do things like they do in the classroom. The things that they teach in the classroom, you're not going to see that. You're going to see a much more darker, seedier side of society than what they teach you in class. And so then scores start to come down. And that's been true in medical school, nursing school, paramedic school, all of them, that once they start interacting. Now, some of them can come back up. It depends on how you handle them, the students, and then in the providers once they graduate. So once they get into the actual practice and they're taking care of patients, there's ways that you can foster empathy and sort of get them back to a good level. But you have to take an active process at that. It's not something that's going to happen organically. It's going to you have to take steps to do it.
And it dovetails too right into another soft skill from the affective domain, which is that resilience.
Yeah.
And I was doing a okay job in preparing them in empathy and having some of these other soft skills. But what I found about 3 years ago or so was I started seeing and hearing from my graduates that after 2 years, they were out. And I said, why are those rates going sky high in my graduates? And I started talking to them and they went, because this is not the culture. This is not the community. I cannot make any changes. They're just jerks. I can't do this.
So the EMS culture is what you're talking about, not that necessarily as a result of the patient. It's the management, it's the organization.
Never quoted the patient. Nope, never quoted the patient. The only time that they ever mentioned
but yet the
a
patient is the one who is the victim of this.
Yeah. Wow. The only time they ever said anything about the patient was that they were just sick with how they were treated and how their partners were treating them, in the unconscious bias that they were bringing in, and just sometimes the overt aggression or feelings that they had towards those patients. And those were the things that they were talking about, that I can't, this isn't a culture and a community that my mental health will survive. And therefore I moved up and moved out. And they did have the ability to do that because they were prepared in a number of different ways. They come out with a degree that gives them some upward mobility in other directions. But they moved up and out, and every single one of them said that was not the culture we came out of in class. We didn't get to cherry pick our partners anymore like we did for our preceptors, because in class they just moved to a different preceptor that actually did empathetic care and had some of this affective domain. They changed what they could change, which is what I taught them to do. And that saved their mental health throughout paramedic school. But then just getting ingrained in that community and culture, they were out.
Yeah.
They were out.
And there's not very much published data on what happens once people get out, even in the medical, for medical school. You can monitor them all the way. And I think there was one study where they actually did go 5 years after graduation to see where they were on an empathetic scale. And they had overall they had regained a little bit of it, but they weren't like back to baseline at any point. But that kind of stuff hasn't been done in the EMS community. We don't know really that much about empathy, what happens once they get out of school. I have some ideas about what I think happens, but it's just completely anecdotal. It's just things that I've seen, but there just isn't any data.
There's one study done by Bill Leggio and Mike Miller, who talked about the perception of the unhoused population as it relates to EMS and the emergency department. And it's very negative.
Yeah.
So, and these are EMTs, paramedics that have been functioning for a while. They're not students necessarily. So the empathy, they lack it. The affective domain, gone. So, and that's, I think, that culture that you're talking about, Megan, that the paramedics, EMTs have been indoctrinated to say, that group we don't treat well, this group we don't treat well, that group we don't treat well. And it's unfortunate, but it's kind of like a tradition that's carried on from one generation to the next. The students, once they graduate, they have this positive aspect, this positive affect, and then they get indoctrinated into the culture, which is very negative, which is apparently what your students are experiencing.
Yeah.
So.
Yeah. And I think a lot of that goes back to how we are treating mental health.
Yeah.
Wherever that chapter is in that person's curriculum, right? Is that something we're glossing over, or is that something that we are living every day when we have the privilege of setting that community and setting that culture and really supporting to be better in EMS. And I think that we don't focus enough on talking about some of the psychological trauma that we endure and that our patients
Which is a lot.
endure.
Right.
Yeah, it is. It's a massive amount, and some of the coping mechanisms, for better or for worse, right? Because they have a place. Some of the coping mechanisms of being very cynical, of being very, well, no, I didn't go to sleep until 2 a.m. and I was up at 4. And, it's the third day that I've been awake. I don't think we're spending enough time talking about the mental impact that has on decreasing the empathy that we have for others. And so if we're not talking about that either, then we're just falling victim to it on top of it. And thinking about how can we improve those things? Well, that starts with, how am I treating my students, right? Am I empathetic to them when they come in? Do I give them the ground rules? And then do I follow up with those ground rules? And do I treat them empathetically across the board? And that can sometimes be really hard when you get a student that your personalities do not mix. You would not be friends with them. That can be dig deep and really give them the same experience that everybody else has. But that also takes a lot of mental health and emotional intelligence on the educator. Right? They have to be in a good space to do that. I saw one of my colleagues has a board on the wall in an initiative that they were trying to do, where it was, you come into work and everybody put down, where are you? Are you green on the stress continuum? Are you're having a good day? Are you red and you really need like some really targeted help, right? Like, are you red? Like, where are you? And he makes fun of it a little bit because he's like, no one's going to put red. No one wants to be, on a hold.
Targeted.
No one wants that. But he did mention that you can still use that to say, yeah, I'm having a good day. I've got a lot of mental reserves to help someone else. Because we've all had those days that we're like, you know what? Just stay away from me for the first 4 hours. I need this, I need that, but just stay away. And without understanding that and without really focusing on that and acknowledging that we are human and we have emotions and we have to really think about that, we're going to fall victim to it as well. And then we just continue those behaviors.
It's similar to between providers and students. So a provider who's out there taking care of sick people, taking care of injured people, those providers also have things going on in their lives. They got spouses, they got children, they
have life.
They got bills to pay, and all those things that cause stress in someone's life. But yet you're trying to take care of patients. And students, the same thing. They're under stress because of the class, but they come to class with a spouse, with children, with bills to pay, with all kinds of things that create problems for them that are outside the classroom. And generally, I would think an instructor doesn't know that. It's like, you gotta focus on this. You gotta focus, and we don't think about what's going on in your life and that could be impacting your ability to learn or your ability to take care of patients if you're already out there, and we just don't. I'm encouraged that I think there's a bigger focus on mental health care in EMS now than there was certainly when I went to paramedic school back in, the 1800s. But I think that people are, and still there's a lot of old school people that are going, get out of here with that whole mental health thing. I never had that and I'm doing just fine. And then you try to talk to that person and go, dude, you're not doing fine. You need to get some help. You need to get somebody to talk to. But I think that we're paying much more attention.
So you talk about it from the student's perspective as far as the why. Why are they cynical? Why are they dark? Why are they lacking in empathy? What about from a clinician's perspective? Why are they? I mean, is it the life issues that, in the fire department or the EMS organization or wherever they may be, we don't recognize the whole person, the 360 view of an individual. Is that perhaps why? Or?
I think it's probably a pretty big reason why.
Yeah.
I have a friend who has kids, and I walked in one day and the child is trying to learn an instrument, and I'm listening to it, and my friend just goes, oh, it's just terrible to listen to this stuff. I'm like, you and I both grew up that we did this, and you learned this exact instrument. Like, is it easier helping them? Why would I help them? It was hard for me. They're going to have to learn the same way. And I went, maybe. Can we shift that can you imagine how much less stress you would have had and how much better you would have done if you had that? Guess what? You can be that person for your child, right? And I think shifting some of that mentality, and it is a mental health thing of, for my friend, she had not had that, right? Hadn't had that, well, you're right, it should have been better for you.
Yeah.
And once we shifted that, it was absolutely monumental. I didn't think it was going to be monumental, but it was monumental. And now they were helping. The next time I came in, they were doing better and they were engaged and they were empathetic towards their child in learning this. And it was so eye-opening for me to see that little bit of a shift of, yeah, you should have had that. I'm so sorry you didn't. How can you not let somebody be in that category too?
Yeah, how can you let your child have a positive experience unlike yours? Yeah. And unfortunately, I think in EMS, we tend to carry on that tradition of, well, this is how I had it. As you said, the 1800s when you were educated, but we know that's not the case. we don't have to continue on that tradition. We can actually create a new mold, create a new experience, create an opportunity for clinicians to provide empathetic care, positive experiences with the patients. And we know that, I mean, as you said, the disparate outcomes for patients based on race, based on you don't look like me, you don't act like me, so therefore I'm not going to give you pain medicine. Right. We know that there are differences in care. So how do we change this? What's the solution for changing this? Certainly in the classroom, which is the focus of our conversation today, but also in the field. How do paramedics, how do EMTs, how do clinicians change this culture?
So I have lots of thoughts on them. Hence
a podcast.
Works out well. Yeah. So I think it starts on day one in education, and even before they even enter into the classroom, set them up for success, be on the same team, be part of that community, and also recognize that you're going to make mistakes as educators, as program directors.
So in other words, we're human.
Yeah. Isn't that weird? Like that whole mental health component to it for ourselves as well. And I think that's a massive part of it, because if we're not able to be self-reflective on any one of these levels, then we're going to continue to perpetrate this. And so I think when we bring it into the classroom, we bring it in on day one and we bring it in with our instructors and our educators and our students, and we set that culture, we also should continue that into the educational realm of the ambulance, because that's another facet of education. It doesn't stop at the door, it goes to the ambulance. And so I think we start to shift this culture in this community by really finding those people that are in this space that want to join forces here. We had a job fair the other day, and it was absolutely amazing that you would think that the employers would be kind of like competing with each other for students. And it was amazing to see the mental health side to this, that they were healthy enough to say, you know what? We're all here for the same reason, which is to better EMS. And if my company culture isn't what you're looking for, I think you'd fit in over here with this employer really well. And we all started talking about this mental health. How do we make the community better? How do we become more empathetic providers? And I think it starts with finding your community. It starts on day one of supporting that community, and then being self-aware enough to dispel some of these myths. It took me a very long time to not go into the classroom and talk about, well, it's been 2 days that I haven't been able to sleep, or that, these other things are going on. that doesn't have a place in the classroom, right? And so if we further this negative culture, of course that's what we're going to get out. So it's starting that community, and then it's bringing in more people that fit into that community and really spelling it out really nicely so that students don't have a gotcha moment, or that we're physically and passively on the same page with them too.
Yeah, and I would add that take it to the next step after that. It's once they graduate school, I think that those mental health, same sort of focus that you have on empathy, that you have on mental health, that you have on taking care of patients, that whole look at the situation, that's got to extend into continuing education.
Yes.
So that you're bringing it year after year after year, that you're touching on those subjects, you're fostering empathy. Now, certainly, one of the first steps is you have to acknowledge that these things happen. We have to acknowledge that there's these
And the research is
disparities.
showing that.
There's no question about it, right? But there still are a lot of people that hold out that, I don't make that decision based on, well, maybe you don't, but this industry as a whole does. And it's interesting where you wouldn't think, for example, even in cardiac arrest, like the depth of chest compression is different between men and women. How long a woman waits to be defibrillated once the ventricular fibrillation is found is much, much longer than it is for a man. And it's just things that you wouldn't even think that are somehow playing out. But you have to acknowledge that those things are there, and then you have to fix them. You have to go in and say, here's how we would combat that. Maybe it's procedural, just the things that we do procedurally. But then the other part is, I think that you have to sort of tap into this affective domain, and I think you can. And the research does show that there is an ability to foster empathetic care and empathy within an individual. There's ways to do that, whether it's through role models, through what's it called when I pretend to be a patient, you pretend to be, and then we have an interaction, and then we talk about our behaviors and what words you could have used differently and those kinds of things. So it's that there's several things that have been found, at least in medicine and at the medical school level, to foster empathetic behaviors among the healthcare providers. And I think that should just become part of a CE program, that maybe once a quarter you touch on something that would tap into some empathetic thing. You show some video, and then we all have a discussion about what we saw, what was right, what was wrong. Did they do this? Not necessarily did they do the procedure correctly, but what do you think about their attitude towards this individual? Because there are, again, just like you said with the unhoused, there's some studies out there that have looked at paramedics, that are there some groups of people that paramedics just don't really care for. And there are, people that have drug addiction, people that have mental health issues. And we generally have a negative attitude about those people compared to someone who's having chest pain, or someone who got hit by a car or something like that. But, and medics often use terms like, well, you're in trouble now because of drug addiction, but that was because of choices you made. And we forget
Which is
that
not the words that need to be
exactly
heard by the patient.
Exactly. It doesn't make any difference at that point. They're in crisis, and you got to fix that, regardless of how they got there. So there's ways to do it, and I think you're right that it starts in school, but then you have to take it to the next level in the continuing education, and then that just has to be a lifelong process, as long as they're in EMS, and your departments have to do it.
I also think there's a call to action to leaders and managers. I know that the AAA, American Ambulance Association, published a couple years ago the number one reason for leaving EMS, or number two, one or two, was because of poor management leadership. So I think, leading by example, providing a culture that is positive, that is patient-centered, is important, which patient-centered includes being empathetic, having the appropriate affective skills, being emotionally intelligent. If we had that culture, it probably leads to less people leaving the profession, leaving the organization. So I think there's a call to action to leaders and managers as well.
And I would add on to that too, your medical directors.
Yep.
Because I cannot tell you how many students and graduates and providers, and myself, quite frankly, have chosen locations to work based on the medical director. Am I going to be
Good or
stressed
bad?
out? Yeah, exactly. Am I going to be stressed out that entire shift looking over my shoulder because I know I have to answer to them being very hardcore on something and and not in my corner and not part of the patient care continuum? Or is this a conversation? And some of the best medical directors treat it as a conversation and as, no, this isn't punitive. Yes, we still have boundaries, and we should 100% have boundaries across the board everywhere, right? As educators and providers. But even as medical directors, are they treating it as punitive? And that's the environment that I'm in, that people are waiting for me to do something wrong. Or is this a growth environment? Is that medical director a leader to be part of the care team for that patient? And I don't think that can be understated. I think that when you look at leaders as medical directors too, some of the best medical directors are the ones that know their providers and they are partners, right? Even if that provider makes a mistake, that provider knows, no, I don't have to worry about being restricted and not having the ability to put food on the table. Because when you start talking about humanity on that level, you know what? I'm going to lose that empathy real fast because it's going for myself, as opposed to I'm strong enough and supported enough to be able to give that to someone else. And that's massive.
Yeah, absolutely.
All right. Well, there's a lot more that obviously we could discuss about this, but the affective domain and in particular empathy, which both of you have passions about, as we're filming this from the NREMT conference. Meghan, you presented on that, and Kenny, you're working on your doctorate degree on that. So I appreciate you taking this brief amount of time with me to talk about the importance of affective domain and perhaps how we can have it more in our classroom, but also, as we talked about, how we can have it more in the field and instill it and make sure that it's present and of importance in the field. So thank you.
Well, thank you for having us and letting us bring it out to the community that this is a direction that we need to go.
Perhaps we have a follow-up conversation about this in the future. So
I think it's a start. Yeah, absolutely.
All right. Thank you both for joining
Thank you.
me.
Thank you.
And thank you for joining us. And as always, stay safe.
Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications about upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.